This video provides a recap on gastro-oesophageal reflux disease and the management thereof. Hi there, I'm Dr. D and a registered pharmacist. Gastro-oesophageal reflux disease is commonly referred to as heartburn and a common medical disorder. I will highlight some important points that you as a pharmacist or healthcare professional can apply when supplying medicines either over the counter or by doctor's orders. You can click on this link to view the video on the 3 phases of dispensing. I will include this link as well as the resources used in the description below. The pathophysiology of GORD is multifactorial. The symptoms and complications result from the reflux of acid or bile from the stomach into the esophagus, but it can extend to the oral cavity, including the larynx or vocal cords or the lungs. When the reflux is extraesophageal, the patient may present with chest pain, hoarseness, sore throat, chronic cough, and even asthma. To identify the severity of a condition, it is necessary to question the patient regarding the signs and symptoms, identify any risk factors, and counsel the patient regarding any food or medication that may worsen the condition. Food or medicine can act as a direct irritant to the gastrointestinal mucosa, or it can decrease the tone of the sphincter where the esophagus enters the stomach. But more on this in a little while. The most common signs and symptoms a patient will present with includes heartburn, hypersalivation, belching, and regurgitation. Ask the patient about difficulty in swallowing, known as dysphagia, or painful swallowing, known as odynophagia. Inquire about any unintentional weight loss or vomiting and if any blood was present. Blood in the stool might not always be visible to the patient, but due to internal bleeding, the patient may present with anemia due to the lower hemoglobin levels. In more serious GORD, the symptoms can be tissue injury based and includes inflammation of the esophagus, known as esophagitis. The signs and symptoms in red requires referral to a medical doctor for further investigation. It is important to keep the extraesophageal signs and symptoms in mind because a patient might have a low-grade reflux and not even complain of heartburn as such. Pay attention to the risk factors that may contribute to GORD. These include a family history, smoking, alcohol consumption, and obesity. Pregnancy is another contributing factor in females. Some respiratory diseases, certain medicines and foods may also aggravate GORD. During phase 3 of dispensing, you can provide non-pharmacological advice and address the risk factors that applies to the patient in front of you. A patient will describe the condition as a sensation of warmth in the chest area or burning up from the abdomen that may radiate to the neck. Ask the appropriate questions to rule out any foods or medicines that may be a direct irritant to the esophageal mucosa. Patients suffering from these symptoms should avoid spicy food, orange juice, tomato juice, coffee, and tobacco. Medicines that can aggravate or exacerbate the signs and symptoms of GORD include non-steroidal anti-inflammatory drugs, iron supplements, and medicines used to treat osteoporosis. Again, counseling of a patient on exactly how to take these medicines is a very important function of the pharmacist. The pathophysiology of GORD includes an increased transient relaxation of the lower esophageal sphincter or less, or a reduced tone of the sphincter. Should the patient present with signs and symptoms of GORD or receive medicines to treat GORD, counsel and educate the patient on the types of food that can worsen the condition. Alcohol, for instance, increases peristalsis of the esophagus and the frequency of the contractions. Also take note of the medicines that decreases the leg pressure and confirm if the patient is perhaps taking any of these medicines and address it then accordingly. Other causes of GORD include hiatus hernia, abnormal esophageal acid clearance, and delayed gastric emptying. What will be your goal of treatment? Well, it will definitely be to alleviate the symptoms, to decrease the frequency or to prevent a relapse, to promote healing of the injured mucosa, and to prevent complications, and to overall improve the quality of the patient's life. Whenever assisting a patient, you also have to provide non-pharmacological advice applicable to the patient in front of you. As healthcare professionals, we should encourage patients to quit smoking, but even more so when suffering from GORD, because not only does tobacco decrease the leg pressure, but it may be a risk factor for Barrett's esophagus and esophageal adenocarcinoma. You can advise the patient to elevate the head end of the bed, to avoid tight-fitting clothes, eating smaller meals, and avoid retiring directly after a meal. It is also good to always remind a patient to take his or her medicines in an upright position and with a full glass of water. Always apply your country's rules and regulations when supplying medicines, and remember to work within your scope of practice. The pharmacological treatment of GORD includes patient-directed therapy with non-prescription antacids, H2 receptor antagonists, and proton pump inhibitors. It also includes prescription strength acid suppression therapy and, in certain circumstances, pro-motility agents. To treat milder symptoms of GORD, an antacid might just provide sufficient relief. Agents including aluminium and magnesium hydroxides and calcium carbonate will decrease the activation of pepsinogen to pepsin, a proteolytic enzyme. Antacid offers quick relief, and they help to maintain the intragastric pH above 4. They neutralize the acid, and this then also helps or leads to an increased pressure of the lower esophageal sphincter. Another common agent used is alginic acid, which forms a highly viscous solution that floats on the surface of gastric contents. So it serves as a protective barrier. It will protect the esophagus against a reflux of the gastric contents. Non-prescription H2 receptor antagonists or H2 blockers, they are also effective in diminishing gastric acid secretion, and they have a much longer duration of action when you compare them to antacids. These H2 blockers, they will bind to H2 receptors on the gastric parietal cells and will inhibit both meal-stimulated and basal acid secretion. Proton pump inhibitors irreversibly inhibit hydrogen potassium ATPase, which is the enzyme responsible for the final step in gastric acid secretion from the parietal cells. And the PPIs maintain the gastric pH also above 4. This class of medicine is more effective compared to your H2 blockers. It is important to refer a patient if no response to lifestyle modifications and after 2 weeks of patient-directed therapy. Acid suppression therapy remains the mainstay of GORD treatment. Examples of H2 receptor antagonists include ranitidine, cimetidine, famotidine, and nisatidine. Because all the H2 receptor blockers have similar efficacy, Selection of the specific agent should be based on factors such as differences in pharmacokinetics, their safety profile, and cost. Cimetidine, which is an older H2 receptor blocker, inhibits cytochrome P450 isoenzymes, and these isoenzymes are required in some of the metabolisms of other drugs. So drugs like, for instance, theophylline, warfarin, phenytoin, and propranolol, their metabolism will be inhibited when used in conjunction with cimetidine. So these are drug-drug interactions that you should be aware of. Common adverse effects of this class includes headache, somnolence, fatigue, dizziness, constipation, and diarrhea. Each patient responds differently to medicines and therefore do not experience the same side effects. That is why it is always important to individualize therapy. PPIs are preferred in the management of GORD and superior to your older H2 receptor antagonists. Examples include omeprazole, lansoprazole, and pantoprazole. The different PPIs bind to different sites on proton pumps, and this is the reason for different potencies on a milligram per milligram basis. These agents are inactive prodrugs and weak bases, which means they require an acidic environment to be converted to an active form. To protect the PPI from degradation before reaching the actual site of action, these medications will be enteric coated. This delays absorption and a maximum plasma concentration is reached after 2 to 3 hours. They bind irreversibly to proton pumps in the gastric parietal cells to stop the secretion of acid. The excretion of gastric acid is inhibited in a dose-dependent manner for up to 1 to 2 days. Keep this in mind when it comes to maintenance therapy, where a patient can take a PPI every other day. Furthermore, the sustained duration of acid inhibition allows for once daily dosing. Exceptions, however, do apply, for instance, in the eradication of H. pylori in the management of peptic ulcer disease. But more on this in another video. Another interesting fact is that PPIs only inhibit actively secreting proton pumps and therefore are most effective when given 30 minutes before a meal. Remember these two important counseling points. Do not take antacids with a PPI. Why? Because a PPI requires an acidic environment to be converted to an active form. Take 30 minutes before a meal. Why? Because that is when it will be most effective, because they will inhibit actively secreting proton pumps. Common side effects include headache, dizziness, somnolence, diarrhea, constipation, and nausea. Drug-drug interactions include omeprazole and esomeprazole with the antiplatelet clopidogrel. The PPIs inhibit the isoenzyme CYP2C19, which are responsible for the activation of clopidogrel. In this case, pantoprazole is the preferred PPI to use. Another option is to use prasugrel instead of clopidogrel, as this antiplatelet is not significantly affected by PPIs. Certain medicines, for instance antifungals and HIV protease inhibitors, requires an acidic environment to be absorbed. So remember to individualize therapy and to contact the prescriber when needed. You as a pharmacist play an important role in the management of patients. Promotility agents, also known as prokinetics, are used as adjuncts to acid suppression treatment in patients with known motility defects. An example is metoclopramide. It increases gastrointestinal tone and motility by blocking dopamine D2 receptors. The relaxation of GI smooth muscle produced by dopamine is then prevented, and the resting pressure of the lower esophageal sphincter increased. The reflux of acid from the stomach into the esophagus is reduced. Metoclopramide furthermore increases acetylcholine release, activating muscarinic receptors in the esophageal muscle. This leads to accelerated gastric emptying and an increased tone and motility in the esophagus and stomach. Due to D2 receptor blockade, it causes extrapyramidal side effects, which includes Parkinson-like symptoms, including involuntary movements or tremors, and stiff facial muscles. It is important then, during phase 1 of dispensing, to confirm any other conditions a patient is suffering from, because metoclopramide will be contraindicated in patients suffering then from Parkinson's disease or have any other seizure disorders. Other common adverse effects include somnolence, nervousness, fatigue, dizziness, etc. It is important to monitor and evaluate your patient to ensure that the condition is under control and that the goals of treatment have been reached. A pharmacist will be able to treat mild GORD with antacids, over-the-counter H2 blockers, and proton pump inhibitors. However, patients with more severe symptoms requires intensive treatment followed by long-term maintenance therapy, and you should therefore know when to refer a patient to a doctor for a thorough checkup. Refer to the NICE guidelines for the management of GORD. The link is also provided in the description below. The pharmacist is part of a multidisciplinary team and plays an important role in taking care of patients. I hope this presentation was of value to you. If so, please give me a thumbs up and subscribe to my channel to see more interesting videos. Thank you and bye-bye.